Yeah. So in case you missed the class now, because of some reason, you will get the recording of this, okay, in the app, right? Okay. So I was saying there are two types of analgesics. One is for opioid type, other one is NSAIDs. Example is aspirin, ibuprofen. The difference is NSAIDs are used when the pain is associated with inflammation, right? Inflammatory pain. Example, in case of what, rheumatoid arthritis, when there is gout and all, right? What do you give? You give what? Indomethacin, right? The strong NSAIDs, right? Now, opioid-like analgesics are given in non-inflammatory pain. Okay, can anybody give me an example of a non-inflammatory pain? Cancer pain, right? Pain during labor. These are not because of inflammation. So in these type of pains, what do you give? Morphine, pethidine. Understood the difference? Yes? No? Understood, na? Right? So analgesics are divided into what? Two groups. You have opioid, narcotic, morphine-like analgesics, or you have what? Non-opioid, non-narcotic, aspirin-like, right? Analgesics. Now, aspirin-like analgesics have extra action. They also have what? Antipyretic action. Yes, they are able to what? Decrease your body temperature, right? Apart from that, they also have anti-inflammatory action, right? They are not just antipyretic. Okay, so in this class, we are looking at what? Opioids. Okay, opioid analgesics. Now, where do you get this codeine and morphine from? Opium, poppy. Yes, right. So it is a resin which comes out of the capsule when you make an incision on it, right? A resin oozes out, right? And it contains two types of alkaloids. One is called phenanthrene derivatives. Other one is benzoisoquinoline derivatives, right? So in phenanthrene, what do you have? You have three benzene rings which are fused together. Yes, right. So if they are fused linearly, what do you call this structure? This is anthracene, right? This is not phenanthrene, right? To get phenanthrene, what you should have? You should have three benzene nucleus which are fused in this fashion, right? So this is what? Phenanthrene nucleus. Which drugs have it? Morphine, codeine, and thebaine, right? So phenanthrene derivatives are your morphine, codeine, and thebaine. In this, morphine and codeine have analgesic activity, right? So your thebaine is non-analgesic. Clear? What's not clear? See, if you have any doubt, now you can unmute and ask me. I might not notice the chat, right, while I'm teaching. Clear? So who asked me the doubt? Just a second. Vivo 1904. What's your doubt, child? What is not clear? Unmute and speak. Others clear? Wasim, Sabreen, Sifat, Fatima.
Yes, ma'am, clear.
Okay. Right. So morphine, codeine.
Yes,
Yeah.
it is clear.
Okay. Right. So morphine, codeine, they have analgesic activity, right? Benzoisoquinoline derivatives, you have papaverine, noscapine, right? These don't have analgesic activity. Papaverine has structural similarity to verapamil. Verapamil comes in which class? Verapamil, come on. It's a calcium channel blocker. So what will be its effect on smooth muscles? Smooth muscle
Relaxation.
relaxation. Very good. Yeah. So muscles when they have calcium in it, that when calcium concentration inside the muscle increase, what happens? Muscle contracts. Contracts. Very good. Contracts, right? Now, what is it doing? Verapamil blocking the calcium channel. So calcium influx will not take place, right? So calcium's concentration inside of the muscle will decrease, and that will cause muscle relaxation. That's why verapamil is what? A muscle relaxant. So is your papaverine. Okay, papaverine. So here the drug that we are going to study is what? Morphine and codeine. Okay, codeine. Now, morphine as such has analgesic activity. Codeine doesn't have it. Codeine is a antitussive, right? Codeine as such is what? Antitussive. Now, codeine, when it is taken orally, what happens? Codeine gets converted to morphine in the body, right? And that gives you analgesic activity. Clear or not? So codeine as such has only one activity. What is that? Antitussive. It will what? Depress your cough centers, no? Right? And prevent you from coughing, right? When you have unproductive cough, right? Which is tiresome, right? So that is the use of what? Codeine. But when in body it is converted to morphine, you get what? Pain relief also, right? So if you are giving codeine for pain relief, it will be considered a prodrug or an active drug.
Prodrug.
Very good.
Prodrug.
So prodrug only when it is given for what? Pain relief. Okay, not when it is given for antitussive action, because codeine has inherent antitussive action, right? It doesn't need to get converted to morphine. Okay. Now, so what is the major use of these opioids? It is what? Pain relief only, right? Now, on which receptors do they act? They go and act on opioid receptors. How many do we have? 3. Mu, kappa, and delta. Okay, we have 3 opioid receptors. All 3 are G protein coupled receptors. Okay, enable the camera and sit, children, in class, right? It will help me understand whether you are what, able to follow or not. Okay, your faces tell me a lot. Yes, if I disable the camera and teach you, will you be able to understand better? Yes or no? Will you be able to understand it? If I disable the camera, my camera, and then teach you? No, no, it will be difficult for you. No? Same thing happens with me also. No? When you disable the camera and sit, I will not be able to see your face. Your expressions tell me a lot, right? So today I'll give you a bit what excuse if you want, right? You're not you might not be prepared, but tomorrow onwards, what it should be what camera should be enabled. Okay, right? So mu, kappa, delta receptors. What type of receptors they are? G protein coupled receptors. Okay, receptors. Now see, when these drugs go and act on mu, kappa, delta, all 3 produce what? Analgesia. So action on all 3 receptors produces what? Analgesia. Okay, analgesia. Now morphine mainly acts on mu receptor, and it has got addiction property, no? Right? Your opioids, they cause what? Addiction. Do NSAIDs cause addiction? No. So that is one more
No.
difference between these 2 classes, right? So euphoria is because of its action on which receptor? Mu receptor. Okay, mu receptor. See, if the drug goes and acts on kappa receptor as agonist, it will cause what? Dysphoria. Understood? The opposite of euphoria, right? So suppose there is a drug A and there is a drug B. If A goes and acts on mu receptor and produces analgesia, B goes acts on kappa receptor, produces analgesia, which one will the patient prefer? One that causes euphoria or one that causes dysphoria?
Euphoria.
Euphoria. So A or B?
A.
Yeah, right. Sabrina is right. So A, right? So what is the example? So you have morphine, heroin and all, they act on mu receptor. Then you have drugs which act as agonist on kappa receptors, right? Pentazocine, nalorphine, nalbuphine, butorphanol, right? They act on what? Kappa receptor as agonist and produce analgesia. They are also called kappa analgesics, right? Analgesics. So they are not preferred by the patients. Clear? You know the reason, right? Okay. Understood now? Yes. Now,
Excuse me, what is dysphoria?
what is euphoria? Who can explain? What is euphoria? Anybody?
Happiness, like you'll get.
The patient get kick na, when they use
Yes.
morphine, right? It is addicting in nature. Na? Opposite of that is dysphoria. You have a feeling of dislikeness. You don't like it when you take it. Okay. Euphoria, you like it when you take it. Clear? Hope it's clear, right? Okay. Now, what is the other actions? See, on respiratory system, na, it has a depressant action. So there will be what? Respiratory depression, right? The stronger the opioid, more respiratory depression it will cause, right? Now, it will also reduce your GI motility, right? Reduction in GI motility will cause diarrhea or constipation.
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 Constipation. So respiratory depression is one thing, right? If respiratory depression occurs in your body, oxygen concentration will increase, or that of carbon dioxides?
Carbon dioxide.
Carbon dioxide, right? And carbon dioxide concentration increases. Carbon dioxide in blood causes vasodilation. Just remember that. We'll need it. Okay, clear? Right? Okay. Now, reduced GI motility results in constipation, right? Constipation. Then, what is the effect on your eye? Meiosis. Meiosis. Okay. And the a symptom, classical symptom of opioid toxicity is pinpoint pupil. Okay, pinpoint pupil, right? What your this thing pupil is what? Completely constricted, resulting in meiosis, right? So those who are what abusing opioids, right? They will have respiratory depression. They will be constipated, and their what? Pupil size will be very small. Okay, pinpoint pupil, right? Pinpoint pupil. Now, this is common with all what receptors, right? Kappa also, you will see what reduced GI motility, right? Respiratory depression or not. Clear na? Yes.
Yes.
Right. Now,
Yes, ma'am.
now how does the question come in exam? So you have strong agonist, right? In this itself, you have morphine, codeine, fentanyl, right? Oxycodone, all these drugs, right? Now, how do they ask you? See, the patient was when he was admitted, he had what? Respiratory depression, was constipated, and had pinpoint pupil. Which drug was he abusing? Okay, and in option you will have morphine, right? Fentanyl, then heroin. Which one do you think will be the answer?
Morphine.
Morphine.
Morphine, fentanyl, or heroin? See, which is the drug of abuse here? Which is not allowed in our country?
Fentanyl. Heroin.
Fentanyl is used, right?
And
Morphine is
heroin.
given to cancer people. Is
Heroin,
heroin?
I think.
Heroin.
No,
Heroin.
heroin is not used, right? So
Yes,
drug of
yes.
abuse, something that is not but allowed in a country is what? Heroin, right? So if you have all all the options are what? Opioids in answer, right? All will cause this, but the strongest is what? Heroin. Okay, in causing this. So answer will be what? Heroin. It's not because others are wrong. In question, they will ask you which is most correct. Clear? Hope it's clear. Right. Okay. Now, inside of the cell, now, it's the charge inside the cell is usually what? Minus 90 millijoule, right? Negative or positive? Negative. So inside of the
Negative.
cell is what? Always negative, right? If this negativity is reduced, we call it what? Depolarization. Okay, if it is becoming less and less negative and finally positive, we call this depolarization, right? How does that happen? Minus 90, right? A positive charge comes in. What will happen to minus 90? It will become what? Minus 80, then minus 70, right? Like that, it will decrease and finally become what? Positive. Understood? This is called depolarization. Okay, depolarization. Whenever there is depolarization, there action actually happens. Action takes place. Means stimulation is what is happening, right? Now, if the this thing understood, what is depolarization? Yes, inside the cell is becoming what? Less and less negative, no? Right? And it is moving towards the positive side. Yes? No? Understood?
Yes, understood.
Understood, no? Right? Now, opposite of that is when your cell is becoming more and more negative, right? So when does that happen? If a positive ion goes out, it will become more negative, no? Inside. Yes or no?
Yes.
Yeah, right. So minus 100 will become, right? Minus 110, right? So this is called what? Hyperpolarization. You will need this when we go to other chapter also, right? Hyperpolarization. This is what leads to depression of an action potential. It leads to what? Depression of a action, right? Here, your action potential results in what? Pain, right? You want to feel pain or depress pain signal?
Depress.
Depressed.
Depress pain signal, right? So what will take place? Depolarization or hyperpolarization?
Hyperpolarization.
Hyperpolarization. You don't want to feel pain. Na? You're
Uh,
yeah, depressing something. Na? You're depressing what? Pain here, right? So opioids, what do? They cause hyperpolarization, right? So they make the cell more and more negative or positive.
Negative.
They make the
Negative.
cell more negative, right? How do they do it? I'll tell you. By causing efflux of potassium ions. We have a lot of potassium inside the cell, right? They cause opening of potassium channels and potassium moves out of the cell, resulting in hyperpolarization. Okay, hyperpolarization. Clear or not?
Not.
Not. Okay. We'll take it in a different way. Before that, which is the major intracellular cation? Which is the major extracellular cation? Suppose sodium and potassium come and knock on the door. Okay, they knock here. Who gets the permission to move in? K.
Sodium.
Okay, potassium. It's K, na? Okay, right? It gets the permission to move in. Who remains outside? Sodium. Okay, so sodium is the major extracellular cation. Potassium is the major intracellular cation, right? When opioid is given, what happens? It causes opening of potassium channels, right? So where is the concentration more? Potassium. Inside of
Inside the
cell,
cell.
right? Inside the cell. So it will start moving out, right? It will start moving out. Now, when it moves out, positive charge is decreasing na, inside. Yes or no? Right. So earlier it was minus 90 millivolt, no? Right. So it will become what? More and more negative inside, resulting in what we call it when the cell becomes more and more negative.
Hyper.
Hyperpolarization. Right?
Polarization.
Hyperpolarization. And hyperpolarization depresses an action, right? Potential. Depresses. What is the action potential here? Action potential is what? The pain signal. Clear? Yes, right.
Yes, ma'am.
So it will
Clear.
what will it do? It increases postsynaptic potassium efflux, resulting in hyperpolarization. Okay, hyperpolarization. Next thing, there is one more way in which it does this. See, this is your neuron, na, right? In first class, it might be a bit difficult. Later on, you will tell me what will happen. Okay, we'll build this up, right? When action potential comes, na, in any neuron, what happens is when it reaches the end, synaptic end bulbs. So suppose this is that area, right? Synaptic end bulb. There are calcium channels here, right? When the signal reaches here, calcium channels open, calcium moves in, right? Calcium's concentration inside increases, and that causes exocytosis of neurotransmitters. Clear or not? What I said? Action potential reaches the end, right here in this area. What happens there? Calcium influx occurs. Neurotransmitters that are stored are released. Neurotransmitters go and cause what? They cause pain, right? They go and bind to the receptor, resulting in pain. When you give opioids, they reduce calcium influx. Will neurotransmitter be released? Will it be released?
No.
No. If neurotransmitter is not released, will you have pain?
No.
No.
Two things. Okay, understood. So two things that takes place is what? First thing, potassium efflux and inhibition of calcium influx. Okay, calcium influx. Now, it might be a bit tough, na? See, always remember, calcium has two functions. First, in smooth muscles, in muscles, okay, not smooth, any muscle. If its concentration increases, calcium concentration increases, it will result in contraction that we said, na? Yes. If it is smooth muscle, it will result in what? Smooth muscle contraction, right? If it is hard, there will be contraction of the heart. Okay, increase in contraction, right? Now, if calcium concentration decreases, opposite will take place. Now, smooth muscle relaxation. Yes, right? If it is in blood vessels, what will take place? Vasodilation. Understood, right? So wherever calcium concentration is decreasing, you're seeing relaxation, dilation, right? If it is increasing, you're seeing what? Contraction, right? Contraction. That is in muscle cells. In neurons, what is happening? If calcium is able to enter inside, it will cause neurotransmitter release. Understood? If it is blocked, it will prevent the release. Clear? This thing, two things only. Clear? No.
Yes, ma'am.
So classification. Okay, next thing. Classification. You have natural opioids, morphine, codeine, right? These are the two. Then you have semi-synthetic opioids. How to differentiate, how to find out whether they are semi-synthetic or synthetic. See, at the end, if you have morphine, morphine, what I said? Morphine or morphine. Okay, morphine. This is morphine, this is morphine. Or codeine or codone, it is going to be semi-synthetic. Understood? Morphine, morphine, codeine, codone. Diacetylmorphine, pholcodeine, ethylmorphine, hydromorphine, oxymorphine, hydrocodone, oxycodone, right? So they either have codeine, codone or morphine, morphine at the end, right? So these drugs will be what? Semi-synthetic, right? Semi-synthetic. Others are what? Synthetic. Pethidine, right? Which is also called meperidine. Fentanyl, its co-geners. Alfentanyl, sufentanil, remifentanil, right? Methadone, dextropropoxyphene, tramadol, levorpanol, all are what? Semi-synthetic in nature, right? Okay. Now, one more thing. One question that has come recently, na? They will ask you, which of the following a group is responsible for shorter duration of opioids? Okay. Which group is responsible for shorter duration of opioids? Now, remember, ramifentanil is shorter acting, right? And it has got a group called ester group. Okay, ester group, which breaks down very easily, resulting in termination of action, right? So in question, if they ask you which group is responsible for what short duration of action of opioids, which one will that be? Group is ester group.
Remifentanil.
Ester group. Why? Because ester group is rapidly broken down by the enzymes present in our body. Clear? Clear? Okay.
Yes, ma'am.
Yes, ma'am.
Am I going too fast?
Yeah, too fast.
Too fast. So don't message me. And Newton, tell that to me. No? I might not notice, right? I said I might not notice the message. Okay. Right. So is this clear? Should I repeat what I taught?
So, the ester group is present only in remifentanil?
Ramifentanil. Right. So that's why it is shorter acting. You will not be given the name of the drug. You will be asked which group is responsible for shorter duration of action of opioids. Okay. In DHA exam, this question has been repeated. Okay. Repeatedly coming. Right. So which group is responsible? Ester. We have this enzyme called esterase. Right. Esterase, which breaks it down. Right. That's why it is what? Shorter acting. Okay. Now, next is we have drugs, strong agonist, which go and bind to mu receptors, right? Stimulate it very strongly, right? Then you have moderate or low agonist, codeine, right? So most of the drugs are what? Strong agonist, morphine, heroin, pethidine, methadone, fentanyl, it's cogeners, right? Hydroxycodone, oxycodone, okay? All these are what? Strong agonist. That doesn't mean that they are equal in strength. Because if you look, which one is more potent? Heroin, na? Right? If you compare, morphine and fentanyl, fentanyl is 100 times stronger than morphine. Okay, we are not saying they're equal in strength. We are just saying they all go and bind to mu receptor strongly. Okay, and activate it strongly, right? Now, codeine has a very weak binding to mu receptor. So that's why it is a weak analgesic compared to morphine. Clear? Yes. Okay.
Yes.
Mixed agonist, antagonist, right? So drugs that buprenorphine. Buprenorphine is a weak mu agonist, right? Now here two drugs are there, methadone and buprenorphine, which are given to people who have opioid addiction, right? To help them, but de-addict them, right? So once if you come across a person who is addicted to opioids, what do you give them? You give them methadone and buprenorphine, right? It is called substitution therapy. What is it called? Substitution therapy, right? Therapy. Now, why we don't give an antagonist? See, what does morphine do? It goes and what stimulates the mu receptor, causes euphoria, right? So when you give methadone and buprenorphine, they are weak compared to morphine, heroin, right? They're comparatively what? Weak, right? So they go and bind to what? These receptor instead of morphine. So this methadone, right? Or buprenorphine, they go and bind, they cause a little bit of what? Agonism, right? Less than morphine, right? So if somebody uses morphine, if they are on methadone or buprenorphine, will morphine have receptors to go and bind to? My question is,
No.
no, it will not have. No? Others clear? Vivo 1904. Clear. I'm calling you that name because I don't know your name. What's your name? If you tell me your name, I'll call you by your name. Right. Understood? No.
Yes, sir.
Understood, na? Yes. So what I'm saying is, if somebody is on morphine, right, and we give them methadone or buprenorphine, instead of morphine, buprenorphine will go and bind, right? So even if the patient takes morphine, it will not have receptors to go and bind to, right? So he will not get that euphoria, right, after taking morphine, right? So slowly what will we do? We keep them on methadone and buprenorphine, right, and decrease its dose and finally stop it, right? If you give them an antagonist, they will have severe withdrawal symptoms, okay, which they cannot withstand. It is really dangerous, right? It's never advisable to give them what? A antagonist like naloxone, naltrexone, and all. These are antagonists, which block mu receptors. You can't give them, give those drugs to people who are addicted to opioids. You should give them what? Methadone or which one? Buprenorphine. Okay, buprenorphine. So drugs given to opioid addicts to cause de-addiction, right? To treat them. Drug is methadone or buprenorphine. Clear now? That point? Yes.
Yes.
Okay. Then we have antagonist. Okay, drugs that go and block mu receptors, right? Naloxone, naltrexone, and nalmefene. Naloxone is a drug that is given when there is acute opioid toxicity. What did I say? Acute opioid toxicity, right? Somebody abuses morphine, takes too much of it, right? What do you give? You give them naloxone, right? Why? If you don't give them, the patient may die because of respiratory depression. Understood? The patient may die. So to prevent him from dying, what do you give? You give naloxone. Okay, naloxone. Now, another patient is there who was addicted to morphine. We treated them using methadone and buprenorphine. Now the patient is okay now. Now we are leaving him, right? So we don't want him to start using morphine again. Okay, abuse it again. In that case, what do you give them? You give them naltrexone, right? So naltrexone is a drug which is given to post-addict people. Post-addict, not to addicts. It is given to whom? Post-addict, right? Means those who have been treated, right? Those who have been taken to what? Rehabilitation center, treated with methadone, buprenorphine. Now they are okay. We don't want them to start using or abusing heroin or morphine again. What do you give them? Naltrexone. What does it do? It goes and blocks the receptor, new receptor, right? So even if the patient takes morphine, morphine will not be able to go and bind and produce euphoria. Understood?
And naltrexone is given SOS or like in a routine?
Not SOS. It is given to them to prevent them from what? Abusing morphine or heroin.
Like in buprenorphine, they are given
Not,
daily.
buprenorphine is given when they are being treated. Na? But see, you have a patient, right, who is an addict, right? What do you give them first, Sagar? You give them what? Naltrexone, sorry, you give them methadone
Methadone.
or buprenorphine, right? So what does that do? Buprenorphine will go and bind to the receptor, right? This patient was using heroin, suppose, right? He's an addict. So you cannot give them what? You can't stop heroin in them abruptly. That will cause severe withdrawal symptoms, right? Which they cannot tolerate. So we have to give something which is very light, but doesn't cause what? Euphoria much, right? So that's why we give them buprenorphine or methadone, right? So we give that drug, slowly decrease the dose and finally stop it, right? So the patient will not have withdrawal symptoms. Now the patient is okay, right? Ready to go to home. But the thing is, he knows the kick that morphine brings, heroin brings, right? So he may have that craving for it. We all like ice creams, right? We crave for such things, right? Same thing happens, right? So to prevent them from using it again, what do? We go and we give them a drug which can block these receptors for long, right? Prevent them from reusing, right? So that drug is what? Naltrexone. Naltrexone. It is given to
Like
us.
sorry. Buprenorphine is given as a substitute therapy in a
Substitution
tapering
therapy.
of dose. And
Huh.
naltrexone is given afterwards.
Afterwards, once the patient is completely treated. It is okay to go home. Understood? Yeah. Right. So naltrexone is given to post addicts, right? Whereas methadone and buprenorphine is given to addicts. Clear, na? Right. Okay. Other drugs are your tramadol, tapentadol, right? We'll look at the drugs
So,
one by one.
ma'am, basically, this drug, naloxone is an antidote for the morphine, right?
When there is overdose, right? When there is overdose, when there is toxicity with opioids, the antidote is naloxone, not naltrexone. It is what? This is the antidote.
Okay.
Okay, in
What
opioid
about, okay.
toxicity. Any other doubt? No, no. Shall I move to the next slide? Yeah. So
Yes.
morphine. Morphine is the gold standard for severe pain, right? Now what does it cause? We said, what is the effect? It gives us pain relief, right? because of its action on mu receptor, it gives us euphoria. What is the effect on respiratory center? Causes respiratory depression. What is the effect on eye? It causes meiosis, right? Pinpoint, we said, no? Pinpoint pupil, right? What is the effect on GIT tract? Reduces motility, resulting in constipation, right? Constipation. What is the effect on CTZ? Your chemoreceptor trigger zone, which is seen in the brain, right? Any drug that causes stimulation of CTZ will result in vomiting, nausea, vomiting. Understood? Nausea and vomiting. So any drug, if it has the ability to stimulate chemoreceptor trigger zone, it will cause nausea and vomiting. So your morphine has that potential. That's why it causes what? Emesis. Okay, vomiting. Clear? Right. So
Yes.
see, what is the reason for death when there is morphine overdose? It is respiratory depression. Okay, respiratory depression. Now, these drugs, opioids, these drugs have the potential to cause histamine release. What do they cause? Histamine release, right? Release. And histamine release, whenever histamine comes, now, by heart two things. One is it has the potential to cause vasodilation, right? Second thing, it can cause bronchoconstriction. You will need this when we go to what? Type 1 hypersensitivity also. It is what? Dictated by histamine only, right? So bronchoconstriction. Two things, what? Vasodilation and bronchoconstriction caused by histamine. Okay, histamine. Vasodilation, what will happen to BP?
BP decrease.
BP will
Rising
fall, right? Bronchoconstriction. Bronchoconstriction. Can you give this to
constriction.
asthma people with asthma? Bronchoconstriction
Decrease low.
will get constricted. Will the patient, will he be able to breathe?
No.
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 Right. So the drug is contraindicated in asthmatics, right? If somebody comes to the hospital, have some, maybe a cancer patient, right? He is in severe pain. You can't give them opioids. Why? Bronchoconstriction. Understood? You'll have to go and look for something else, not morphine, right? Morphine. So in asthma people, what it is contraindicated because it has the potential to cause what? Histamine release. Okay, histamine release. Now, another thing, it causes vasodilation. There are two ways in which it causes vasodilation. First thing, remember, respiratory depression results in what? Building up of carbon dioxide. What does it cause? Said before, na?
Potassium influx.
Vasodilation. Remember, histamine release can also contribute to vasodilation. So morphine has the potential to cause vasodilation. Now, suppose you have a box, right? Filled with water, right? To this, I have placed a balloon. What did I place? Balloon. Okay, a balloon. Then I closed it completely and inflated the balloon. What did I do? Inflated the balloon. What will happen to the pressure inside the box?
Rises.
It will increase. Understood how? Because what? Balloon got inflated, right? The pressure inside the box is increasing. Same thing happens in your brain also. The fluid present in your brain is what? CSF, right? Cerebrospinal fluid, right? When there is vasodilation, pressure inside the head also increases, right? Understood. So that's why if there is head injury, you should not give morphine, opioids. Clear? So there are two major contraindications to the use of morphine. One is, come on, asthma.
And
One is
asthma.
asthma. Second one is head injury. Why?
Head.
Because it has the potential to increase intracranial pressure. Clear? Pressure, right?
Excuse me, can you please tell once more about the head injury?
Head
How
injury.
how the intracranial pressure is increasing?
Yeah, this box example you understood.
No. Can you repeat once
I'll
more?
repeat. Okay, just a second. What I said is, so you take the brain, right? In
Mhm.
brain, what do we have? We have ventricles which are filled with what? Cerebrospinal fluid. They are lined
Fluid.
with blood vessels, right? They're lined with what? Blood vessels, right? Now, when you take morphine, what happens is there is vasodilation, right? Vasodilation. So when vasodilation occurs, the pressure inside the head increases. Understood?
Okay.
All right. So when pressure inside the head increases, if somebody is having head injury, there is chance of bleeding. Bleeding increases, right? There is already injury. So if pressure inside the head is increasing, right? You want to get what? Pain relief. You might get it, but at a cost, Understood? So if somebody is having head injury, never give them morphine. If somebody has asthma, don't give them morphine. Clear?
Okay.
Okay. Next, uses. Okay, major use. We said analgesia, right? They can cause constipation and decrease GI motility. So drugs like morphine are used in diarrhea. Morphine is not used. Drugs like morphine, which have agonistic action on mu receptors. Example is loperamide. Okay, loperamide. That is used in what? Diarrhea. Morphine also has antitussive action. Morphine, enable the camera and sit, na children. Yeah. Morphine also has antitussive action, right? But it is not preferred. Which one is given? Codeine, right?
Codeine.
Codeine is preferred. Why? Because morphine has abuse potential, right? Okay. Now it is used in acute pulmonary edema. How? Pulmonary edema, right? Now, this is your heart, suppose, right? Left side, right side, right? Left side contains oxygenated or deoxygenated blood. What?
Oxygenated.
Oxygenated.
Yeah, it contains what? Oxygenated blood, right? So if it contains oxygenated blood, it is coming from where?
Lungs.
Yeah, it's coming from lungs, right? And is going to different body parts, right? Body. Okay.
Yes.
Now, in left-sided heart failure, right? Your heart is not able to pump blood, right? It is not able to pump blood from left ventricle into the artery, right? Why? Because the pressure inside the arteries is really high. So what is the problem here in the left-sided heart failure? Pressure here is high, right? High. That's why heart is not able to pump the blood from the left ventricle into the artery, aorta, right? So what happens? Where does the blood pool? Blood pools in the left
Left
ventricle,
ventricle.
right? So will the blood come from the lungs to the left ventricle? Will it be able to come if there is no space?
Oh,
No,
No.
right? Well, where will there be edema? In the lungs, no? Fluid buildup will be there in the lungs, no? Because the blood is not moving into the heart. Understood? So in left side heart failure, what do you see? The symptom? Dyspnea.
Pulmonary.
Breathing. Why? Because there is edema in the lungs. Understood?
Lungs.
Yes. Now, what do? You give morphine, right? What does it do to your blood vessel?
Blood vessels,
Dilation.
vasodilation.
Right. If it causes vasodilation, what will happen to BP?
BP decreases.
Decreases.
Very good. BP decreases. So what will happen to the blood? Heart will be able to pump blood, no? Now, right? So the blood will move from left ventricle into the blood vessel.
Aorta.
So there will be what? Room for the blood from lungs to come in, right? Understood? So there will be difficulty breathing. Dyspnea won't be there, right? If there is acute pulmonary edema, what do you give the patient? IV morphine.
Morphine.
Give them IV morphine, right? And that will relieve dyspnea, difficulty breathing. Why? Because of its vasodilatory action.
Dilation.
Clear? Children?
Yes, ma'am.
Okay. Next is codeine. Codeine, a prodrug when we are considering analgesia or antitussive action.
Antitussive.
Okay, antitussive action. Good. Now, codeine is converted to morphine, we said, right? By an enzyme called CYP2D6. By heart, this enzyme. What is enzyme? CYP2D6. Okay, CYP2D6. Before we go into it, let's look at this structure of morphine. Morphine has what type of structure? Phenanthrene nucleus. Can you see if I draw here? Will you be able to
No.
see? Yes or no?
No.
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 Just a second. Right, I'll draw it here. Okay, draw here. You can see, na? Right, so this is your phenanthrene nucleus, right? Here you have the A ring, right? And this, I'll show you just, okay. So just a second. I need space to write here. So this is your A ring, this is B, this is C ring, right? C ring. Okay. Now, this is your, okay, then you have one hydroxyl group here and one hydroxyl group here. This is your morphine. What is it? Morphine. How do you number? You start from here, right? 1, Very important. Okay, DHA people who are writing DHA, concentrate. Okay, 1, 2, 3, 4, 5, 6, 7, 8, right? Then you have 9, 10, right? 11, 12, 13, and 14. Okay, this is how it is numbered. Understood, na? From where to start and where to end, right? Now, what is the difference in morphine and codeine structure? Morphine has her phenyl group here, no? See, a hydroxyl group here and hydroxyl group here, right? If you remove this H and replace it with CH3, what do you get? You get methyl morphine. Okay, methyl morphine, which is other name of codeine. Okay, so only structural difference in morphine and codeine is this methyl group. Methyl group, right? So if you want to convert morphine or codeine to, this is if you have your CH3, morphine to codeine, what do you need to do? Methylation or demethylation?
Demethylation.
Sifat, understood? Are you there? I can't see you, that's why I'm calling your name. Sifat, are you there? Mirza, what should I call? Hello? Be there in class, okay? Important question, multiple times it has been repeated. Which enzyme is responsible or which reaction takes place, right? Codeine to morphine conversion. Which reaction? Demethylation or methylation? It is
Demethylation.
demethylation, right? Which enzyme is involved? CYP2
CYP2D6.
D6. Okay, CYP2D6, right? So codeine, you have this methyl group here, right? Morphine, you don't have, right? Codeine is getting converted to morphine by eliminating a methyl group. O at O position, demethylation. Which enzyme? CYP2D6, right? So if somebody is having active CYP2D6, only then they will get pain relief, na? Yes? Not clear?
No.
See, codeine gets converted to morphine with the help of which enzyme?
2D6.
2d6.
Yes.
CYP2D6.
Now, if somebody is having a defective CYP2D6, means defective enzyme, will they be able to convert codeine to morphine?
No.
No, right? So, case study. A patient comes to the hospital with severe pain. He was given paracetamol without much decrease in pain, right? Understood. Pharmacist, or the prescriber, physician, what did he do? He added codeine. The patient comes the next day saying that he doesn't have any pain relief, right? It is as if he was taking only paracetamol, right? So even after giving codeine, he was not experiencing any decrease in pain, right? Question will be, what is responsible for this, right? So the thing is, he might be having a defective CYP2D6 enzyme. Understood? Multiple times this question has come, right? CYP2D6 enzyme, right? So what do we call such people? We call them poor metabolizers. They are not able to metabolize codeine to morphine. Are they able to convert it from codeine to morphine? Are they able to convert?
No.
No, they are not able to convert codeine to morphine, right? So they are called what? Poor metabolizers.
Metabolizers.
Okay. We normal people, see, I'll tell you one more thing. This thing we will learn in more detail when we go to pharmacogenetics, but you need to understand one thing. You have two copies of the same gene in the body. No? Gene is something, see, in our DNA, understand this. Okay, there's no need to learn, understand this. In DNA, very important it is, right? DNA, you have certain portions which are called genes, right? And you get one copy from your mother and the other copy from your father, right? So we have two copies of the same gene, two copies of the same gene. They are called what? Alleles. What are they called? Alleles, right? They code for the same thing. One we get from the mother, one we get from the father, right? Okay. Now, if somebody is having what? Defective gene from the mother as well as the father, they will not be able to convert what? Codeine to morphine. Not even a little bit, because both are what? The mother gene as well as the father's gene is defective.
Poor
Understood?
metabolite.
Poor metabolizers. They are poor metabolizers. Now, if both are active, then he will be a normal metabolizer. There, the normal doses, when you give, he will have what? Pain relief, right? Some people have extra copy of this gene. Extra copy. Understood? Multiple copies of the same gene, right? So they will be called what? Extensive metabolizers. What they are called? extensive metabolizer. Why is it a problem? Because all the codeine you give, na, it's rapidly converted to morphine, and that results in opioid toxicity.
Toxicity.
Toxicity. And toxicity, you will see what severe respiratory depression, constipation, pinpoint pupil. Understood? You will have to give them naloxone, right? So both is a problem. Both is a problem. What? Both are problems. What? Being a poor metabolizer, the patient will not be able to convert codeine to morphine, no pain relief. Being an extensive metabolizer, he will convert all the codeine to morphine rapidly, resulting in opioid toxicity. Okay, that is also a problem. Clear now? So patient comes to you, clinic. He was prescribed codeine, but he shows the signs and symptoms of opioid toxicity. What might be the reason? What might be the reason?
Maybe they are extensive metabolizers.
He is a extensive metabolizer of which enzyme? Enzyme is?
H2D6.
Okay, clear now?
Yes,
Very
ma'am.
important, very important. Next is semi-synthetic opioids. Okay. So codeine, mild pain relief, antidepressive action, right? Opioid receptor, it is a weak agonist, right? Compared to morphine, all those. Codeine is what? Weak agonist. Heroin, it is diacetyl morphine. Now what you have here, hydroxyl group, na? Right? What is this group called? CH3COOH? Acetic,
Salicylic.
acetic acid, normal thing, acetic acid. Now if you remove this H, right? And add this CH3C double bond O, CH3C double bond O, you get what? Diacetyl, na? Acetyl group, na? Di-2-acetyl group, diacetyl, same thing, morphine. What is it? Heroin.
Oh.
What is it? Heroin.
Heroin.
Okay, heroin. So morphine, when it is acted upon by acetic anhydride, which has this two group, na, see, right? CH3COO, right? You get this CH3COO, CH3COO, right? You get what? Diacetyl morphine. Clear?
Yes, ma'am.
Yes. Next is oxycodone, hydrocodone, right? They are given orally, right? They are what? They are given for moderate to severe pain. Okay. Abuse potential is there because like morphine, it goes and acts on what? Mu receptor as agonist, right? So sometimes people, what do they do? They take it, right? And crush the tablets and what? To get that euphoria, they abuse it, right? And that results in what? Overdose. Fatal overdose means respiratory depression. Okay,
Yes,
respiratory. Next is pethidine. Okay. Do you need a break? A 2-minute break. Do you need? Or shall we continue? If you want a break, I'll give you a 2-minute break. You can go and drink water and come back if you want to.
No.
No, right. She doesn't want. Is there anyone who wants? Sabreen, Archana.
No.
But are you there, Sifat? Just want to know.
No, ma'am. Yes, ma'am.
So I'll continue. Okay. The thing is, no, usually I give a break after 45 minutes because as humans, we have that much capacity only, right? Later on, you will understand. Okay, so synthetic opioids. If you take just 2 minutes break, na, it will reset your mind. Right. Let's see how much concentration span you have. I don't have it. Okay, much. Synthetic opioids, right? Pethidine, meperidine, both are same. Pethidine or meperidine, right? It is a bit different from your normal opioids. Why? What do normal opioids do? What is their effect on eye? Because mydriasis or meiosis?
Meiosis.
Meiosis. Pethidine causes opposite thing. It causes mydriasis. Okay.
Yes.
All other opioids will cause meiosis, but pethidine, meperidine, they cause what? Mydriasis, right? Mydriasis. Also, they are converted to, this meperidine is converted to an active metabolite called normeperidine in the body. Okay, normeperidine. Okay, normeperidine, right? And this is mainly eliminated via renal route. Which route? Renal, right? Renal route. So normal people, it's okay, right? Pethidine or meperidine will get converted to normeperidine, right? It will get eliminated via renal route. But in elderly people, they have compromised renal function. As we age, our renal function gets compromised. Yes. And in people who have renal impairment, what happens? Normeperidine accumulates, right? And that accumulation results in neurotoxicity. So it is toxic to neurons if it is not eliminated completely. Clear? Yes. So pethidine, meperidine is okay in normal people, but not in elderly or in those with renal impairment. Why? Because it gets converted to a active metabolite called normepiridine, which has toxic potential. Okay, it can cause what? Damage to the neurons. Okay, neurons. Okay. Now, it is something which is given in labor pain, right? Why? Because it's respiratory depression caused by it is what? Less, right? Those who have given birth, if you have given birth by normal delivery, you might know what happens when the mother is what? When she's in labor, the heartbeat of the child is always monitored, no? Right? To know that the baby is what? Okay, right? Any drug that causes respiratory depression will not be preferred during labor, right? Pethidine is a drug which is safe. Why? Because compared to other opioids, it causes less respiratory depression, okay, especially in the baby, right, inside the womb. So preferred in labor. Which one? Pethidine, mepiridine, right? Fentanyl, 100 times more potent. What question comes? Fentanyl is used as patches also, right? Now, if somebody is using fentanyl patches, make sure that their body temperature don't increase. Why? If the body temperature increases, fentanyl's absorption through the skin increase. What happens? Through the skin, fentanyl's penetration will increase, and that can result in opioid toxicity. Clear or not? What I said?
No.
See, somebody has placed it, suppose, right, on the skin, right? Body temperature should be maintained at normal level, right? If body temperature increases, what will happen? Fentanyl's absorption into the blood will increase, resulting in toxicity. Understood? No, still no. No, na?
Understood. Understood.
Understood, all of you. If you didn't understand, the thing is you need a break, right? Because what I have said is easy to understand. Clear? Yeah. So heat increases what? Fentanyl's absorption from the patch, right? Its permeability is increased, right? So if somebody is having fever, right, you should not use it, right? It may cause toxicity. Should never what? Go and use what? Heating pads or electric blankets, or use a hot tub while you have placed fentanyl patch on your body. Clear, na? It will result in toxicity, right? So what you need to monitor when somebody is on somebody has placed fentanyl patches on their body? Body temperature. Body temperature. Never allow it to rise. Okay, rise. Next is methadone. What is the use of methadone that we have studied? Methadone use.
Opioid addiction.
This is for
Substitutive therapy.
right? So detoxification. And the problem with one problem with methadone is that it can cause QT interval prolongation, right? Very important point. QT interval, any drug that has the potential to cause QT interval. What is QT interval? ECG, na? This is the graph, right? You have P, Q, R, S, and T, right? This area is called what? This thing is called. We'll learn the details in the CVS chapter. Okay. So QT interval, any drug that has the potential to increase this QT interval will cause a fatal arrhythmia called torsade D points. Torsade D points. Fatal, right? Fatal, right? So if somebody is having arrhythmia, right? Somebody has a risk of arrhythmia, you should not give them methadone, right? Because it will cause QT interval prolongation and has the potential to what cause torsade D. Okay, torsade D points, which is a fatal arrhythmia, right? Fatal arrhythmia. Which other drugs have this potential to cause QT interval prolongation? You have fluoroquinolones. Okay, fluoroquinolones, your ciprofloxacin like drugs. Ciprofloxacin like drugs, right? Fluoroquinolones. Then you have macrolides. Can anybody give me an example of a macrolide?
Erythromycin.
Erythromycin.
Erythromycin. They have this potential to cause QT interval prolongation. So they
These
with caution in people who have risk of arrhythmia. Clear, na? Yes.
these drugs cause diastolic pressure decreases now.
Diastolic pressure increase or decrease? You're asking that? No, they don't have much effect on that. Pressure. See, we say opioids cause vasodilation and decrease in pressure, but the action is not that significant. Not that significant.
It only affects the ECG.
Only affects the
ECG.
ECG. Methadone only, not other opioids. Methadone,
Mm.
right? Next is tramadol. Tramadol
Ma'am.
should
Now,
uh,
just tell me torsidy point again.
torsade points is a fatal arrhythmia, right? So if somebody is having any type of arrhythmia, suppose, right? To such a person, if you give methadone, no, their QT interval will get prolonged, right? And that can cause what? Torsade points. If you look at the ECG, na, a wave like this is what is seen. How it should be usually? Should be like this, na?
Like this,
Like this it should be, right? But it appears like this. This is called what? Torsade points. Dangerous arrhythmia, it is fatal if it is not treated suddenly. And the drug that is given is usually magnesium sulfate, right? A drug that is given to treat eclampsia in pregnant women, right? Magnesium sulfate, right? Severe rise in BP, which causes epilepsy, right? That is eclampsia, no? Pregnancy, right? Magnesium sulfate is given. Same drug is given to treat torsade points also. Clear? Right. Now, tramadol. Tramadol. It is a, see, opioid agonist it is, okay. But apart from that, it has got selective, serotonin and norepinephrine reuptake inhibitors. Okay, your SNRIs, no? You have SSRIs and SNRIs, right? Okay, SNRIs, like, who can give me an example? SNRI, anybody? Okay. Yeah. Okay, if you can't give me an example, it's okay. Just tell me what disease it treats. SNRI.
It's antidepressants.
Yeah, they are antidepressants. Okay. So what you have to remember is depression occurs when you have less amount of norepinephrine and less amount of serotonin in your CNS. Okay. In CNS, in brain, if you have less amount of norepinephrine, less amount of serotonin, we are usually what? Depressed. Okay, depressed, right? So what do antidepressants do? They increase the norepinephrine and serotonin concentration by inhibiting their reuptake into the neurons. Okay, so tramadol has a mood elevating property also. Clear? Mixed agonist, antagonist, okay, and partial agonist. Buprenorphine, what is the use?
Again, in the as
What is the
a
use? Buprenorphine, methadone.
opioid addiction.
It's given to people who have
Substitution therapy.
substitution therapy.
Substitution
Opioid
therapy.
substitution therapy. That is a major use. Okay, they are safer because they cause less respiratory depression, like your mepiridine, right? It also causes less respiratory depression, especially fetal. That's why it is given in labor, right? Pentazocine, they are kappa agonist, right? That's why they cause what? Dysphoria, right? Lower abuse potential. Because they cause dysphoria, they are limitedly used because patient don't like pentazocine or nalbuphine, right? They will not prefer it. Okay. Next is opioid antagonist, right? Okay. Now, I'll draw the structure of morphine, right? For you, you can see the structure now that I'm drawing. That area,
Yes.
yeah, right. So okay. Now, this is morphine, right? This is morphine. If you look here, what is N attached to? N is attached to methyl group, right? Now, if you look at antagonist, you have naloxone, naltrexone, methyl naltrexone and all. What are they attached to? They are attached to larger groups, no? Are they? Bigger groups. Yes. Important, very important. Question has come. So nitrogen attached to a smaller group, drug will act as a agonist, right? Nitrogen attached to bulky groups, they will act as antagonist. Clear? They will act as antagonist. Okay, naloxone, bulky group, naltrexone, here also bulky group. In morphine, what you have? CH3, na? Small group, right? Understood? Yes or no?
No.
No. See, what do you have here? In morphine, what is N attached to? CH3, no? Attached to CH3. Now, if you look at the structure of naloxone, see, here you have CH2, right? CH2, no? Right? CH2, CH, CH2, right? This is your CH2 followed by the cyclopropane, right? Bigger groups, no? Here you have only methyl group, na? Only CH3, right? Here you have bigger groups, na? So what I'm saying is, if there you have bigger groups, what will happen? Instead of
Antagonist.
new agonism, drug will start showing antagonism. Understood? Antagonism. So how do you understand? See, how do they give the question in the exam? They will ask you which of the following is given in opioid overdose, opioid poisoning, right? You know the answer, it is naloxone, but they will not give you the name of the drug. Okay, technician people will be to them the what name will be given, but those who are writing pharmacist exam, DHA pharmacist, right? For them, naloxone might not be mentioned. They will be given just the structure, right? How to identify? It is easy to do. Why? If there is bulky group, it has to be what? Naloxone, right? See, naltrexone if it is antagonist. So they are asking again here. You have a bulky group, right? Now, if you look at the structure of codeine, how was the structure? Just a second. See, CH3 only. Codeine, CH3 only. Yes. I'll show you others also. Just a second. So morphine, this is codeine. Just a second. See, oxycodone, oxymorphone, all have what? CH3 only, no? Small groups. They are all what? Agonist, right? But naloxone, naltrexone and all, what do they have? They have a bulky group. Clear?
Okay.
Okay. So, competitive agonist, what is the use of naloxone? Acute opioid overdose, right? Opioid toxicity, you give naloxone. How do you give? Given as IV.
IV.
Because it has short duration, you may have to repeat the dose.
Repeat the dosing.
Repeat the dose. Naltrexone is longer acting oral antagonist, right? When do you give? You give it to block the opioid receptors, na? Completely block it. In whom? Post addicts. Okay, not in addicts, but in post addicts. Okay, post addicts. Now, naltrexone also reduces alcohol cravings. Okay, so not only given to opioid addicts, but also to alcoholics. Okay, alcoholics. Clear now? Yes. What are the uses of opioids? Analgesia, right? Suppression. They can be given in diarrhea also, right? Because GI motility, they will decrease na, by acting on receptors, mu receptors on GIT. What do? Decrease GI motility. So in diarrhea, if you decrease GI motility, the patient will be okay, na? Right? Which are the drugs? We'll take it in detail. Okay, loperamide and diphenoxylate. Okay, pulmonary edema. Do you give them IV? Morphine.
IV morphine.
Anesthesia, fentanyl, ramifentanil, right? Short-acting drugs are given. What is the adverse effect? What is the effect on respiratory system? Respiratory depression. Respiratory depression. If there is respiratory depression, what do you give?
Naloxone.
Naloxone, right?
Naloxone.
Constipation. It can cause constipation, no? Right? If it causes constipation, right? You may have to give what? A drug. See, if it causes constipation, which is moderate to severe, right? Moderate to severe constipation. We are not talking about addicts. We are talking about, suppose, cancer patients who have no other choice but to use morphine for pain relief. Understood? Fourth stage cancer patients might be using morphine for what? Pain relief, right?
Pain relief.
It is given to them, right? Now, when they use it, they are always what? Constipated, right? And it is a big problem to them. No? They are not able to what? Defecate properly. Yes. So what is the option? We give them antagonist, which will act only on the periphery. Now, if you give them naloxone, what will happen? It will go and see, we need action on the brain, but not on GIT, no? Right? This is the brain, right? Here there is mu receptor, brain. Okay, brain. There is mu receptor. And on the GIT, there are mu receptors. When you give morphine, it acts on both areas. No? Brain, it gives what? Pain relief, right? It acts on brain, gives you pain relief. It acts on the GIT, causing what?
Constipation.
Right. So if you give naloxone, it will go and block both, no? Right? And you will not get pain relief also. Yes, so you cannot give naloxone. What do you give? You give methyl naltrexone. What do you give? Methyl naltrexone. Right? What is the difference? See, you add a methyl group here. At this place, you are adding what? A methyl group. It gets converted to methyl naltrexone. Okay. And that gives the ammonia, the nitrogen atom, a positive charge. What is the structure of nitrogen? Ammonia. It like this, no? It has 3 valency and a lone pair, right? If any groups are substituted here, there is no positive charge. If the fourth valency is also utilized, nitrogen attains a positive charge, right? If it attains positive charge, it is polar or non-polar now?
Polar.
It becomes polar, right? If it is polar, will it be able to penetrate blood-brain barrier?
No.
It will not be able to penetrate blood-brain barrier, right? So it will act only on the periphery, na?
Only on smooth muscles.
Only on GIT. In the
GIT.
periphery, right? In the periphery, right? So naltrexone, if you give, it will go and block both the opioid receptors, means those in the brain and as well as in the GIT.
GIT.
But you want the action on the brain, but not in the GIT, because that is causing constipation. What do we give? We give methyl naltrexone. Because methyl naltrexone has a positive charge, it will block the receptors on the GIT, but spare the receptors on the brain. Clear? No.
Yeah.
I'll make it simple. Others understood?
Yes.
Sagar, Archana, Sifat, Maria. See, if you have not understood, ask me to repeat. I'll repeat in another way. Right? Make sure things are clear by the time I finish it. Clear or not?
Yes, ma'am.
If it is not clear, say no, not clear. I'll repeat. Sagar, clear?
Yes, ma'am.
Sifat,
Please, can you please once repeat that?
you want me to repeat, right?
Yes, ma'am.
Say that. Now I know. Listen. See, there are two types of drugs. One is a polar drug, one is non-polar drug, right? When do we call a drug polar? When it has a charge, right? We call it polar, any charge, positive charge or negative charge. Okay, now if drug is polar, it will be what? Water soluble. Water soluble, right? If drug is non-polar, it will be non-water soluble. That is, it will be lipophilic, right? Water soluble means it is hydrophilic. Okay, so these are different terms. Polar drugs are usually water soluble. They are what? Hydrophilic. Non-polar drugs are what? Lipophilic. Now, how do they differ in their action? See, this is blood-brain barrier. If something has to reach brain, it will has to cross this blood-brain barrier to reach where? CNS, right? Water-soluble drugs or hydrophilic drugs will not be able to penetrate blood-brain barrier. Understood? Non-polar drugs or lipophilic drugs, they will be able to penetrate blood-brain barrier, reach CNS and produce action. Is this much clear? Sifat.
Yes, ma'am.
Yeah. Now, see, your methyl naltrexone has positive charge, no? Yes?
Yes, ma'am.
Naltrexone doesn't have, right? So we are dealing with a patient who needs pain relief, but is troubled with constipation, right? So needs pain relief means on brain, he want mu receptors to be active, right? But on the GIT, he wants it to be blocked, right? So there is what? A blood-brain barrier here, right? When you give methyl naltrexone, which is an antagonist, because it is positively charged, will it be able to penetrate blood-brain barrier?
No.
No. Sifat?
No, ma'am.
No, no. So if it is not able to penetrate blood-brain barrier, it will not do anything on the brain. So the patient will continue to get what? Pain relief. Yes, but it will be able to act on periphery. It will go and block the mu receptors on the GIT. Yes? Fatima? Yes? Yes, right.
Yes,
So,
yes.
yes, right. So there won't be what? Constipation. Clear? So drug which is given, a drug that is given to treat opioid-induced constipation is what? Methyl naltrexone. Methyl. Okay, clear now?
There's an opioid induced.
Constipation, opioid-induced constipation. OIC, moderate to severe. Constipation which is induced by more opioids use. Methyl naltrexone. This question has also come. Methyl naltrexone. There are other drugs, naloxegol and naldimidine, right? Of the same class, Pamoras. which is peripherally acting mu opioid receptor antagonist. But in most of the cases, option was methyl naltrexone, right? Clear? Yes, right. Now, tolerance and dependence. See, if somebody is using morphine, they will get tolerated to its euphoria. Means if they use it for long, they will need more amount of morphine to get the same height or this what euphoria, right? Same kick, right? But they don't get tolerated to two side effects, which is constipation and meiosis, right? Constipation, meiosis still continue to happen. Doesn't matter if they take more dose or less dose, right? But to get euphoria, every time they take, they will have to take a little bit more, okay, to get the same euphoria, right? And there is called cross tolerance between among or not between among opioids. That is, if somebody is abusing morphine, they might have to take a lot of oxycodone to get the same euphoria. Understood? A small dose will not do that. Okay. And if somebody is on morphine and if they suddenly stop it, there will be what? Severe withdrawal symptoms also, right? Meiosis is caused by most of the opioids. Pethidine or mipridine causes what? What does it cause?
Mydriasis.
Mydriasis.
What is the contraindication? The two major contraindication. Asthma and
Head injury.
Head injury.
now, in renal impairment, we have said that pethidine should not be used, right? Because it is converted to normepiridine, which is having neurotoxic,
Neurotoxic.
right? Which other drugs should not be used? Codeine and propoxyphene. Which other two? Codeine and propoxyphene. Okay, renal impairment. Which other drugs that are considered safe? Methadone and fentanyl, right? Methadone is more safe than fentanyl. Both are safe, but methadone is more safe, right? More safe. Now, in pregnancy, you should not use what? Opioids for long. Why? Because, see, opioids,
Renal something.
no. You can, okay, this
Fetus.
opioid, they can cross placenta, right? They can cross placenta, reach the fetus, right? So baby is experiencing all the effects of what? Opioid. Once the baby is born, he will have withdrawal symptoms. Child will have what? Withdrawal symptoms. Understood? Mama will still get it, but baby won't get it. No? Yeah, right. Okay. Now, anti-motility drugs used in diarrhea. Which two we have seen already? Loperamide and
Loperamide.
diphenoxylate. Right, diphenoxylate. Now, they are mu agonist or antagonist? What do you think? They're used in diarrhea. They decrease GI motility.
Motility.
So what do?
Antagonist.
Agonist.
Sabrine.
G.
Huh. Agonist or antagonist?
Agonist.
Agonist.
If I didn't hear you. No.
Agonist. ma'am.
Agonist. Agonist, na, Sabrine? Fatima.
Yes,
Agonist,
yes.
na? Why? Because opioids, what do? Decrease GI motility only. Na? So diphenoxylate, loperamide, what will they do? They will decrease GI motility. They are mu agonist, like morphine. So they have abuse potential. Yes? They're also mu agonist, right? So diphenoxylate, to prevent its abuse, a little bit of atropine is added to it, right? So if somebody, say in a tablet, when you buy Lomotil, which is the brand name, it will have diphenoxylate and a little bit of atropine. If somebody takes multiple tablets, okay, in order to what? Get the euphoria, atropine's concentration will also increase, right? Little bit of atropine will not cause much problem, but if multiple tablets are consumed, atropine's concentration will also increase, and that will cause what? What will that cause? Anticholinergic side effects. Okay, anticholinergic side effects. What are they? Decrease in sweating, resulting in increase in body temperature, right? Dry mouth, all those things. Okay, we'll learn the anticholinergics and all in the ANS chapter, don't worry. Okay, so atropine, anticholinergic side effects are seen, right? So to prevent its abuse, what is added to diphenoxylate? A little bit of
Atropine.
okay. It should not be given to children less than 6 years of age, right? Next is loperamide. Loperamide, again, it has its own anticholinergic activity. So that's why it is not used or sorry, abused. Okay. Diphenoxylate, if you don't add atropine, people will abuse it, but loperamide is not abused because it has its own anticholinergic property, right? So that's why it is given as OTC product. Clear? Should not be
Hmm.
given to children under the age of 4 years. Okay, 4 years. Next drug is resigadotryl, which can be given to children, right? Then it is not contraindicated. So diphenoxylate should not be given to children under the age of 6 years. Loperamide should not be given to children under the age of 4 years.
4 years.
Considered safe in elder people, right? Adults. It is an OTC product also. You can give loperamide unless your stool is what? Bloody. Okay, should not have blood in it, right? Or a foul smell, which will which happens when you have infection, right? So loperamide can be taken if the stool and all is what? Watery. There is no problem with it, right? If there is blood in stool or if it is foul smelling, loperamide should not be given, right? The thing is, it might be caused by what? A protozoa or a bacteria, and body is trying to what? Get rid of it, no? By causing diarrhea. If you take loperamide, but it may get prevented, no? Right? Complicating the condition. Understood? Why?
Yes, ma'am.
Okay. Right. So morphine to heroin, what happens? Morphine to heroin, acetyl group are added, right? To acetyl group are added. Codeine to morphine, which is methyl morphine. Codeine is methyl morphine. So methyl morphine getting converted to morphine. Demethylation or methylation?
Methylation.
Demethylation.
Demethylation, right? It's called
Demethylation.
O demethylation because methyl group is attached to oxygen, right? So it is O demethylation. Opposite. Morphine to codeine. What are you adding here?
Methyl group.
Methyl group, right? So it is methyl,
Methyl.
right? So
Methyl
if it
group.
is opposite, it will be what?
Methylation.
Methylation. Okay, methylation.
Wait a minute.
Okay. Now, one more thing. Last. See, at 14 position, if you have a hydroxyl group, okay, 14 position, if you have hydroxyl group, that will increase your analgesic activity. Okay, analgesic activity. So oxycodone, oxymorphone, and all have hydroxyl group at 14th position. Okay, 14th position. Morphine doesn't have. These have oxycodone, hydrocodone, oxymorphone, and all have it, right? So they have what? Increased analgesic activity. Now, presence of hydroxyl group decreases antitussive activity. Does morphine have a hydroxyl group? Okay, I'll show you the structure.
No.
No,
Yes.
doesn't have. Right, morphine. Does it have a hydroxyl group? No, no. Right, doesn't have.
No.
Right, so it has antitussive activity, no? Does it have?
No.
No.
Morphine.
No.
Morphine doesn't have antitussive activity.
Codeine have anti-TC.
Codeine has,
Codeine.
morphine also has antitussive activity, but we don't use it, no? See, morphine also depresses cuff center, right? It has antitussive activity, but codeine is the gold standard. Why? Codeine doesn't have abuse compared to morphine. Abuse potential is less. Understood? Codeine is also a prescription drug only. You won't get codeine without a prescription. Will you get?
No.
No.
You will not get, right? So it has abuse potential, but it is a weak agonist, right? Morphine is a strong agonist. So it is not used for antitussive activity, right? It's not used for that purpose. What do we use in severe cases? Codeine only, right? Now, what you have to remember is, if you have hydroxyl group, it will increase analgesic activity, right? If you don't have it, that will increase what? Antitussive activity. This question has come. Okay, so 14 beta group. If you have the hydroxyl group, no antitussive activity, right? If you don't have it, the drug will show antitussive activity. Clear? Yes. No.
Yes.
Sifat, clear?
Listener.
Maria, Vivo, Sagar.
Yes, ma'am.
Yes.
Yeah. Now, opioid antagonist. How will you identify? You will have a bulky group attached to nitrogen, no? Right?
Mhm.
So replace methyl group of nitrogen, right, with a bulky substitution. What do you get? You get antagonist.
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 Naloxone and naltrexone.
Naltrexone.
Now, Tramadol is an open ring. Usually we have a phenanthrene nucleus. Na? Here, can you see a closed ring system in this area?
No.
No, right? So tramadol is an open ring codeine derivative, right? It is weak mu agonist. It inhibits serotonin, right? Serotonin and norepinephrine reuptake, increases the concentration of these in the brain, serotonin and norepinephrine, right? Also, the problem with tramadol is that it increases the risk of seizures.
Seizures.
Yes. Okay. Should we go to the questions? Do you have any doubt in the chapter? Chapter is over.
Please explain the first
And
section.
that slide,
Which slide?
morphine to codeine, and
Morphine to codeine. Conversion.
yes, ma'am.
Ask me to stop when I reach that slide. Okay. This one?
No, no,
Ye
no.
dekho.
The conversion,
Conversion is
like
here.
methylation,
Understood.
demethylation, that one.
Understood. Just a second. Ye wala.
Huh.
Oh, sorry. Just a second. Okay.
Please explain first session.
Huh?
First session.
First session?
Explain. Can't hear.
You want me to explain this slide again? What you said is not clear. Unmute, come near the mic, speak loudly.
Please show
ma'am.
us.
Okay, ma'am.
Okay. Who's speaking? Just a second. Huh, speak. Somebody was speaking, na? Yeah. I'm waiting, child, speak. Which slide do you want me to explain?
Questions.
Huh. Right. Shall we look at the questions?
Yes, ma'am.
Saw the answer. Let's see. A 30-year-old patient is given codeine for pain management, right? Codeine for pain management, but experiences no relief. Physician suspects a metabolic issue. Which of the following best describes the metabolic reaction required to convert codeine to morphine? Metabolic reaction that converts codeine to morphine. Now, recall what you studied, connect it with the options given, and give me the right answer. Question is never going to be what? Direct, okay? Acetylation, hydroxylation, dealkylation, glucuronidation. What is the answer?
Hydroxylation.
Somebody thinks it is hydroxylation. Yeah. What is the other name of codeine?
Methylmorphine.
Good. It's methyl morphine.
Morphine.
It is getting converted to
Morphine.
morphine. Right. So which group is being removed?
Methyl.
Methyl. We called it
Demethylation.
and methyl group is what group?
Alkyl.
Alkyl.
Alkyl group.
This is how questions will come. It will never be what? Direct. Right. So this is easy, na? This was not tough, right?
No.
Wasn't, right? So pay attention, right? You need to be what? Very alert when you are what? Answering questions. Okay. Questions will be like this. Understood? Maria, Sifat, Fatima.
Yes,
Okay.
ma'am.
Right. Next one. A patient presents with opioid overdose. Which of the following symptoms would most likely be observed? Okay, symptoms. Dilated pupils and increased respiratory rate, pinpoint pupils and respiratory depression, mydriasis and hyperventilation, meiosis and tachypnea.
Pinpoint pupils and
Pinpoint.
respiratory depression.
Respiratory disorder.
B.
Sure.
B.
Okay. Answer is pinpoint pupil and respiratory depression.
Depression.
If the toxicity is because of mifepiridine, what do you see?
Mydriasis.
The pinpoint pupil, you will see what? Mydriasis. Okay.
Mydriasis.
Which of the following best describes the action of morphine on the chemoreceptor trigger zone? Action of morphine on CT cell. What will it do?
Nausea and
nausea and
vomiting.
vomiting.
It
It
will
in
stimulate the CTZ to cause nausea and vomiting.
Vomiting.
A 45-year-old male with metastatic lung cancer. Okay, metastatic means he is in 4th stage. Okay, stage 4. It has spread to the whole body. Metastatic stage is on chronic morphine therapy. Okay, for pain management. He reports significant constipation despite dietary modification. So he has tried using fiber, right, including fiber. He has tried using what exercise for all to relieve constipation. Nothing is helping him, right? Which of the following drug is most appropriate to treat his opioid-induced constipation without affecting analgesic?
Methyl
methyl
naltrexone.
naltrexone.
Answer is methyl naltrexone.
Naltrexone.
The conversion of morphine to codeine primary involves which of the following reaction? Morphine to codeine.
Methylation.
Methylation.
Codeine is methyl morphine. It is methyl morphine. So morphine is getting converted to methyl morphine. That is methylation. Right?
Methylation.
Another way of saying it is alkylation. Which structural feature of codeine contribute to its antitussive activity? Present, okay, we are talking about codeine. Codeine's antitussive activity is because of what? Which group we are asking? Okay.
Presence of 14 beta hydroxy.
Yeah, it's the right answer. First one is the right answer. Now, the presence of 14 beta hydroxyl group, lack of 14 beta hydroxyl group, presence of 14 beta hydroxyl group is the answer. Presence of a free hydroxyl group at the 3rd position, presence of carbonyl group. Think and give me the answer. What is the answer? Sagar.
Presence of 14 beta hydroxy.
A or B?
B.
No.
A.
Lack of B.
B, na? If you have a hydroxyl group at 14 position, that will increase what activity? Analgesic or antitussive? Analgesic activity. If you don't have hydroxyl, there will be antitussive activity. Anti don't have. Analgesic, you have it. Anti don't have. Okay, anti is negative, na? So negative hydroxyl group, you don't have hydroxyl group. No codeine, right? Antitussive activity, right? If you have it, there will be increase in analgesic activity. Clear?
Yes, ma'am.
So in codeine, you don't have hydroxyl group. Oxycodone, oxymorphone, you have the hydroxyl group. Yes?
Group.
Is the topic clear?
Yes.
The last question,
Yeah,
can you
that's
please
fine.
explain again?
Just